First of all, thanks to all Precision Consortium and mainly our colleagues from BioCat for giving us this possibility to share our reflection and our ideas with all of us. I like to focus in how we are trying to bridge the adoption gap in our healthcare sector. I'm sure everybody agree, and Robert point out that in the last years we have been significantly improved, all related with generation of innovation. Never before so much innovation in companies' portfolio, in research center portfolio, in universities or technological center portfolios. But at the time, adoption into real-world health systems remains slow, uneven, and difficult to scale, mainly difficult to scale. So I will focus on this gap, trying to identify what kind of policies can help us to close this gap. In healthcare systems, we are quite good. We are very good at creating innovation, but at the time we are much less effective in all related with getting innovation to patients. This gap is not a technical gap; it's a systemic gap. So much difficult to solve, and because of this, it's a policy matter. So my presentation looks how we are trying to break down all this process and which kind of policy levels we can address it. So just for trying to identify some main figures or main ideas of this gap: strong research and innovation capacity. At the time, weak, slow, and even adoption into our health systems. Later, I'm going to go deeper in all related with the main bottleneck. This situation is clearly affecting patients, professionals, system efficiency. And if unfortunately nothing changed, we are delaying patient benefits, we are wasting innovation potential, and at the end we are talking about competitiveness and we are losing competitiveness. So we are not having an innovation problem for sure. We are not talking about generation problems. We have clearly an adoption problem. If this is the core problem, this persistence of this gap between innovation and adoption, then the question will be, how is the system trying to address this problem? And for trying to answer this, let's try to look at the policy architecture in healthcare systems, trying to help to solve this problem. And what about this kind of architecture in healthcare system? It exists some main actors: ministries of health, payers and providers. In some healthcare systems, different kind of payers. In some others, only public, a single public payer. Different kind of healthcare provider, public ones, private non-profit, private profit healthcare providers, industry and innovators, startups, professional clinical leaders, evidence actors, knowledge regulators. So different kind of actors, and this difference always try to create a high level of fragmentations. Different kind of instruments, public procurement of instruments, new, more open transferring tools, hospital-driven innovation programs, fostering innovation at hospitals level, new kinds of EU funds, next generation, Horizon, whatever the kind of fund, multi-level governance, regional, national, EU. So capacity is really strong, but unfortunately, alignment is not really strong. So we have a strong policy, institutional architecture, multiple actors and instruments, but the main issue is related with the absence. We have the lack of tools for helping systems to perform in practice. And because of this, I'm trying to identify the main bottlenecks. What are the main bottlenecks that are avoiding us to scale and adopt? Uh, the main bottlenecks are related with regulation, complex and slow to be addressed. About financing, difficult to have specific funds, specific tools for funding all these, for example, regulatory steps, supporting creation. Financing is mainly supporting creation, not adoption. Our procuring schemes are clearly risk adverse. Unfortunately, our data governance is still too much fragmented. Our infrastructure are uneven readiness. It doesn't exist trust between all these stakeholders. It exists that trust gaps across stakeholders, and we are not using the more suitable metrics. We are mainly focusing our healthcare systems mainly in activities, in fee for service, for example, than in outcomes, more based on activity in fee for service than an outcome-based contract, for example. Because all of these, we are quite familiar with all related with TRL, technology readiness level, but we are not so familiar with adoption readiness level, for example, and we need to focus in all related with adoption, customer readiness level, regulation readiness level. With TRL, it's clear what can it work. With ARL, what is clear is, will it be used? And this is some of the big problems. How many patients will be finally impacted? How much time for reaching the patients in our technology transfer process? So ARLs are related with bottlenecks. TRLs are not related with bottlenecks, are related with generation. So once we have a clear idea related with bottlenecks, all these bottlenecks unfortunately are not theoretical, theoretical bottlenecks. So let's try to show some examples, to share with you some examples related with how different systems are facing these bottlenecks. In Catalonia, Robert pointed out how we are addressing the idea to the fact to try to identify some big unmet needs, 8 big unmet needs, in order to try to address innovation generation to solve these unmet needs. So in the last years, the main tool that we are using in Catalonia for addressing this problem of adoption is mainly related with public procurement, trying to co-design with providers, with healthcare providers, of course, and with companies, and trying to get some results and getting some results mainly related with solutions better aligned with clinical needs, improving service delivery, and improving also our capacity and skills for service delivery. And this is directly related with the scaling pilot, for example, getting service delivery skills and capacities, increasing our adoption potential, and getting some main lessons learned. When demand is articulated, innovation follows this demand. So we need to have a clear articulation of demand. The critical gap is only solved if we are solving the problems related with aligning demand. So this is the example for Catalonia. Let's try to share some examples, some other useful examples and situations in other health systems that are also addressing similar challenges. Just sharing with you 3 examples. First, related with Israel. The tool in Israel is more related with health technology assessment prioritization. The main mechanism is related with structuring multi-stakeholders decision making, and the results are clearly related with fast and more legitimate adoption of high-value innovation. National Health Service England is also a big example, an interesting example. There, the tool is related with national programs and mandates. The main mechanisms are related with a top-down push with local implementation. In Catalonia, we're using bottom-up tool and also top-down, so we're using both systems. And in England, the main result is also related with higher scale, but at the time, uneven adoption. And finally, Denmark. The tool there is more related with the digital infrastructure and also having a strong primary care, similar to Catalonia. The mechanism is related with interoperability and system-wide coordination. And finally, the results are mainly related with a smooth diffusion and high clinician uptake. So with these three examples, what is clear is that exist different system levels, all of them related with prioritization, scale, and infrastructure that can drive innovation adoptions. It doesn't exist a single best solution. It exists different good solutions trying to align policy providers and system needs. So what we are seeing from this different international experience is that there is it doesn't exist a perfect model, but it exists in all these model different transferable elements. So then the question is, what can be done in our context? So trying to learn all this approach, for example, what will be the next priority actions for the next 24 months, the next 2 years. I try to identify three main practical actions that clearly can split into actional levels. First, create fast-track adoption pathways. In Catalonia, we call PAS, Robert pointed out, and also shift metrics toward clinical impact. We need to talk about how we are reaching patients. We need to talk about how many patients are getting benefits of these innovations. We need to have information about time to reach patients. We need to get information about adoption of innovation. Second action related with escalation. We need to reform and to use different procurement frameworks, more flexible procurement frameworks, and we need to improve all related with data access and governance. And finally, we need to keep it concrete and credible. So after getting all these actions, these practical actions, let's try to get some final questions related with how we get the possibility to measure all these problems and what matters. We suggest and we are trying to use three main kind of indicators: time from pilot to adoption, and the idea is to reduce this time, percentage of innovation reaching system-wide use, and patient-level impact, if it's possible, finally being measurable. So I suggest you to ask yourself, in order to try to advance with this design thinking approach, if you could remove or redesign one rule, incentive, or maybe a process, what would be? And what would happen next? First question. Second question, what would need to be true for adoption to become the default, not the exception in your system? And finally, I'd like to share with you my proposal for design thinking challenge. How might we reduce time to adoption by 50% without compromising safety, evidence, or equity? So, how we can reduce time to adoption by 50% without compromising safety, evidence or equity. Finally, let me share with you my final idea or my final take-home message. Success of a health system is not what it creates, but what it adopts at a scale. At the end, we are talking about how we are reaching patients and how patients will benefit from our adoptions. So that's all.